Hello, I'm Geraldine Moses. Welcome to this program, Sugar in the Bush, Rural and Remote Diabetes. On behalf of everyone here, I'd like to acknowledge that we are meeting today on the land of the Wangal people. The Wangal people are the traditional owners of this land and form part of the wider Aboriginal nation commonly known as Eora. We also acknowledge the elders and the descendants of the Wangal people. The prevalence of diabetes has more than doubled over the past 20 years. 4% of Australia's population, around 1 million people, now have diabetes. Australians living in rural and remote areas have been shown to have higher rates or risk factors and mortality from diabetes than their metropolitan counterparts. Treatment and management of diabetes can be more difficult in rural and remote areas for many reasons. A lack of local specialists, comprehensive screening programs, travel, time and cost pressures all contribute to this problem. Also, the limited health resources in regional areas are concentrated on the people already known to have diabetes. So tonight's program will look at the particular challenges in treatment and management of diabetes in rural and remote Australia. You'll find a number of useful resources available on the Rural Health Education Foundation's website. That's www.rhef.com.au. Now let's meet our panel. Dr. Pat Phillips is the Director of the Diabetes Centre and Endocrinology at the Queen Elizabeth Hospital. He has for many years been at the forefront of diabetes research and treatment. And he's been actively involved in Diabetes Australia, the Australian Diabetes Society and the Australian Diabetes Educators Association since the 1980s. Welcome, Pat.
Thank you.
Karen O'Dea is a nutrition scientist and public health researcher who's made major contributions to the understanding of the relationship between diet and chronic diseases, particularly type 2 diabetes and related conditions. Welcome, Karen.
Thank you, Geraldine.
Now, Samaria Corpus is an Aboriginal health worker and diabetes educator at the Royal Darwin Hospital. Welcome, Samaria.
Thank you.
And Hugh Heggie is currently the Senior GP for Gunbalanya Community Health Centre, Owenpelly, West Arnhem Land. Hugh and his team provide medical services to the community of some 1,500 predominantly Aboriginal people. Welcome, Hugh.
Thank you, Geraldine.
Now let's set the scene a little about diabetes. And Pat, I'd first like to put it to you. Perhaps you can tell us a little bit about this silent epidemic of diabetes.
You mentioned before that 4% of the population have diabetes. There is actually a slide that we've got which highlights the fact that 4% of people have diagnosed diabetes, another 4% have undiagnosed diabetes, and another 4 people, that makes a total of 6 out of 24, 1 in 4 people have pre-diabetes or diabetes. So this is the slide with the red person in the top corner having known diabetes, the person standing right next to that person having undiagnosed diabetes, and the other 4 people having pre-diabetes. And you can see that that's out of 24 people, that means 1 in 4. So it really is an epidemic, and the trouble is that it's pretty silent because it doesn't have many symptoms.
Yes, no symptoms, so people don't know there's something going on.
You get a bit tired maybe after a meal, but then everyone gets tired, and maybe you haven't got quite as much energy, but you're just getting a bit older. So it's very easy to dismiss any symptoms, and symptoms are often not present at all.
Does this epidemiology apply equally to Indigenous populations as well as non-Indigenous populations?
Well, in fact, as Karen O'Dea is a better person to speak to that, but yes, it's very much so that diabetes is a real silent epidemic, but a very devastating epidemic in the Indigenous population.
Absolutely. Karen, did you have a comment on that?
Yeah, well, we have some data that we'll show in a slide in a moment, which shows that Indigenous people not only have higher rates of diabetes, they actually have much earlier age of onset. So it's a very serious public health problem because it's the number of years that you have diabetes that actually, and the severity of it, that determine the complications. And so when you're getting diabetes in your teenage years, which is actually quite common and very common in your 20s, then you're not going to be very old by the time you're getting renal failure, diabetic eye disease, and greatly increased risk of heart disease. So
you could perhaps talk us through this slide.
Yes, well, you can see from this slide the orange bars from AusDiab, the Australian data for Australia as a whole, and you can see on the far left that virtually nobody Very, very low numbers of people under the age of, from the age of 25 to 35 have diabetes in the wider Australian population. That's actually changing now, and that it is increasing in the wider Australian population. But look at the red bar and the green bar, which are for Aboriginal and Torres Strait Islander people, and you see the very high rates in the younger age groups. And if we had data going down lower, you'd see it in teenagers as well. And what you see with the Torres Strait Islanders, they have half of the population really has diabetes over the age of 50.
And it's diagnosed diabetes?
Yes, this is diagnosed. Well, this was in screening, so
right.
So I guess. But in Aboriginal and Torres Strait Islander communities, there's great awareness of diabetes. So there's much less undiagnosed diabetes in those communities, which is good. But you can, if we go back to that slide, we can see that in older Aboriginal people, 65 and 75 and over, actually have much lower rates of diabetes. This is some Central Australian data, and that's because the people with diabetes have died. And this is reflecting the 20-year shorter life expectancy or more that people with diabetes have.
Very powerful data. So perhaps we can now go on to describing the natural progression of the disease. Pat, would you like to talk to that?
Well, this was demonstrated very clearly in the United Kingdom prospective diabetes study, and there's a slide which shows the relationship of the A1C, which is on the y-axis, and the duration of diabetes during the trial. And the two lines represent the conventional treatment, which was what the ordinary people were treated with back in the 1980s and 90s. And the blue line is the intensive treatment, which is where they really tried very hard. And I guess there's two things about the slide which really come out to me. One is that the people in the conventional treated group never got below an A1C of 7, and the people in the intensive treatment only got down under 7 and stayed under 7 for a few years. So by 3 years they were all over 7%.
Right.
That's the first point. The second point is that there is a relentless, pretty well, increase in the A1C with time. So that you can see that by 10 years, both the conventional and the intensive treatment all had an A1C over 8%. Now, put that in context, that's an average glucose of 10 millimoles per litre. So that's pretty high, and
yes.
People feel relatively comfortable with A1Cs of 8%, but they really do indicate very significant glycemic risk.
So how does this then relate to some of the comorbidities like eye disease?
Well, I'd like to make the point first that I'm talking about A1C, that is the average blood glucose over a period of time, a measurement of it, but the other things which are important are the rest of the ABCs. So there's A1C, blood pressure, cholesterol, smoking and salicylate. But in the context of A1C, there's a slide there that shows the likelihood of people developing diabetic retinopathy. This is as the microvascular complication, and the A1C on the x-axis. And the thing that's striking about that is the lower the A1C, the lower the risk. Now you could do the same with the other ABCs. You could say the lower the A1C, the better, the lower the blood pressure, the better, the lower the cholesterol, the better,
yeah.
and so on. So I think this is applying to microvascular disease, and it's quite clear now that this was the first time we had demonstration that controlling blood glucose in diabetes actually did anything good. And since then, we've become also aware that lower and lower targets are yielding more and more benefit.
So this data almost says, though, that no matter how tightly you control the diabetes, you really can't prevent it from progressing. Is that what we should read from that, or can you indeed prevent the galloping of the disease? I
think the way I read that, the slide of the progression, is that two things. One is that the treatment needs to progress. Now, there was a recent trial, for example, where they were trying to get really good glycemic control, and they pulled down the A1C under 7 and they kept it there. So it can be done, but it just needs to have progressive treatment. And I think the second thing is that although you may not actually get down to the stage where there's no excess of microvascular risk or macrovascular risk, you really decrease it by improving the risk factor profile. So you make a big difference. And this is where you, Karen, have some fairly strong opinions on. You can actually prevent it, can't you, with a lot of the nutritional interventions? Well, I think lifestyle? in theory at least, you can prevent type 2 diabetes, but it's very hard. It's a very great challenge. And keeping fit and eating a healthy diet and remaining lean is the way to do it. It's easier said than done.
But we had some data from Central Australia where we showed that over an 8-year period, and I think there's a graph on that, that if the people who were lean at the beginning, that is a body mass index of below 22, nobody developed diabetes. But even in the upper end of the healthy weight range to BMI 25, you can see there's 10 cases per 1,000 person years. That doesn't sound like a lot, but it's actually very similar to what the rest of wider Australia is. And then you see that in Central Australia, when people even just got overweight, they have very high incidence rates of diabetes. And so, which are really as bad as anywhere else in the world with the high-risk populations. So there's good and bad news here. The good news is that in theory, if you really did work at it, and there are lean Aboriginal people in Australia, and in remote Australia, there are people who live traditionally oriented lives up in very isolated parts of the Northern Territory. They have kept lean and fit, and they eat a lot of traditional food with a very healthy diet, and they don't have diabetes. But it's a very big challenge. And so although I say it's possible in theory, in practice it's very difficult.
Now the person really challenged by this is Samaria. So Samaria, I'd like to hear a little bit from you and tell our viewers about the work that you do as a diabetes educator and Aboriginal health worker in the Northern Territory.
I work with a group at Royal Darwin Hospital, and we do a lot of work with the Indigenous people in remote and urban, and that's a challenge in itself. And the rate of diabetes is just increasing, and especially in the younger generation, the fast food, the introduction of Coca-Cola, and TV, and just everything being so modern, people aren't getting out hunting and gathering, and no exercise, no one's encouraging healthy lifestyles.
And you work also with the gestational diabetes patients?
Yes, and that's just monitoring them, stabilising them within the hospital.
That's fantastic. And Hugh, you're also in the rural and remote situation working closely with patients. Tell us about your experiences.
Yes, I work in a team of some 7 remote area nurses who are very skilled, and Aboriginal health workers, 5 Aboriginal health workers. And I would say that diabetes in our burden of work certainly it amounts to probably 50% of our chronic disease work. Coming back to a point on the causes of it, I think in Indigenous populations there's other complexities like your total life exposure to a number of issues, particularly infections and how healthy your mother was when you were in her tum. And through your whole life, how many chest infections you get and so forth. And I think in rural and remote Australia, it is a significant burden, and we also have quite a lot of more comorbidities, perhaps in wider Australia, and less resources, access to resources. But on the other hand, I'd say that certainly in the Northern Territory, we've got very robust systems in place. We haven't quite cracked it with the with things like some of the preventative stuff, I don't think yet, but certainly in terms of registers and monitoring and management plans.
Let's now go to our first case study, who's a 43-year-old man who works full-time as a grader driver and lives in a remote community, a population of 850. He's married with 4 children and 2 grandchildren, and they all live together in a 3-bedroom house. He supports the Adelaide Crows, and I'm thinking that's a risk factor for diabetes. He has a history of an ACL knee reconstruction from a football injury 10 years ago. He has a family history of diabetes, a mother and a sister with type 2 diabetes, diagnosed in 2004. He himself has hypertension, diagnosed in 2005. He smokes and has done for 20 years, smokes 25 cigarettes a day. He has a modest alcohol intake, apparently, of 8+ beers on a Saturday night. And he's currently feeling well. He's had no sick leave in 3 years. He buys food from takeaway during the week. He wears boots and socks at work. and he likes to go hunting and fishing on the weekends, which is limited by his sore knee. So it's possible that he's now presenting to his GP for discussion about his sore knee. But Hugh, let's say he presents to you as his GP. I guess you'd see him as diabetes written all over him.
Yes, I'd like to think that we already had him on our register, so we knew about him, and we also had some previous baseline investigations and some of his biometrics. I think I'd be investigating, number one, why he came to me on the day, because he may be motivated by his sore knee, or he may have indeed been motivated by one of his relatives perhaps having a major complication of diabetes, because that may help in motivating him to improve treatments. I suppose my main approach is going to be to engage with him and somehow to motivate him to better glycemic control, and I suppose that will involve some time, and I need to prioritise that over time, that we need to address some things fairly quickly and other things perhaps a little bit more slowly. And the essential ingredient to this is going to be to have a very robust chronic disease management plan, and as part of that plan there'll be an annual cycle of care. There'll be reviews and including checks and referrals, but I suppose to understand how we can find a pathway that's realistic.
Yeah, because he'd have a lot of burden already, wouldn't he? He's working hard, he's got the sore knee, so he can't exercise.
Indeed, and I can look through some of those issues and go, well, he may be limited perhaps in his exercise, but maybe there's other ways of pursuing it, and he's getting his takeaway food, maybe we could change that around. So there's already enough information there to work on.
Now, you also find out from him that he's on metformin, he's on 500 milligrams 3 times a day, and he takes his morning medication every day but often forgets the nighttime dose. And he's on glucosamine, 1.5 grams every day for his osteoarthritis, presumed osteoarthritis in his knee. So there are issues there with adherence, aren't there? And it looks like there's nothing for his hypertension. No,
in fact, I think adherence is a problem for all of us, especially medicines that are taken in the middle of the day or twice a day. Again, I think metformin is an essential medication for type 2 diabetes because of its inherent value in a range of ways. We could change the dosage perhaps and the formulation, so it's a slow release medication, and also increase the dosage. I can see over time, if that's not going to be successful, we may need to add a sulfonylurea such as glycoside. Yes, his blood pressure. Combining that together with his uncontrolled diabetes, already his risk factors are going to be going up, and I'd probably add an ACE inhibitor, perhaps ramipril, to that. That probably needs to be done sooner rather than later, and his lipid profile. That may be improved by some lifestyle issues like his diet, increased exercise and some weight reduction, realistic weight reduction, and perhaps for his blood pressure salt reduction as well.
Now, we've already received a faxed question, and perhaps anyone bounce in and answer the question, but it goes along the lines of what you're saying right now, Hugh. The first is, how often should insulin resistance and blood sugar levels be taken, and what management techniques for these should be taken in the rural and remote communities? So if this fellow goes away, we're saying he's got diabetes and it needs further management, how often should he be monitored?
Well, as part of a care plan, he normally would be reviewed at least 3 monthly. With his HbA1c. I think with somebody where you're making changes, it needs to be more often than that, and it might need to be monthly. And in fact, I think from an engagement point of view, then maybe it even needs to be weekly. So I guess self-monitoring, if he's able to do that, got the resources to do it.
Did you want to make a comment there, Pat?
Well, can I just add, I totally agree with you about the A1C monitoring, and if it's been stable and under control for a long period of time, you don't have to measure it all that often. I think the question about insulin resistance, the answer to that is never. And I think for two reasons. One is it's terribly difficult to measure. Doing an oral glucose tolerance test and measuring insulin doesn't really give you much useful information,
Right.
and it's very expensive. And if you do happen to find that the insulin levels are up, you need to interpret them in terms of the glucose, and then what are you going to do? You're going to treat the person clinically. You're going to focus on the F words that you can fix. The 40 and family are fixed, so you can't change them, but you can tackle the fat so that you got one of the F words under control. And you're going to tackle the ABCs, which we were talking about before, and he's got the full hand. He's got all the F words, and he's got all the ABCs out of kilter.
What was the ABCs again?
A1C, blood glucose, blood pressure, cholesterol, blood fats, smoking and salicylates.
Right.
So, and he should be on salicylates, and he's not.
Which is low-dose aspirin.
Low-dose aspirin.
Right.
And he shouldn't be smoking, etc. So he's got the full hand of the F words and the full hand of the ABCs.
Well, let's just quickly talk about low-dose aspirin, because that's one of our other questions. Given the recent Popperdad study that concluded that there was no benefit of low-dose aspirin for primary prevention of heart disease in type 2 diabetes, what do we do now? Should we be using low-dose aspirin?
Well, I think the consensus would still be that low-dose aspirin in someone with type 2 diabetes and one other cardiovascular risk factor is very appropriate.
Which this guy has because of the hypertension.
He certainly does. Well, I've yet to find someone with type 2 diabetes who doesn't have another cardiovascular risk factor. So if one of the viewers knows of a case, I'm quite serious. I've said this a lot of times. They just don't happen.
Right.
So basically, it's aspirin for anyone who moves into the high cardiovascular risk, and that's someone with type 2 diabetes and one other risk factor, and that's most of them.
Yes.
And that's where another one of my sort of summaries comes in, and that's the type 2 tablet. And Hugh was actually identifying that. You were talking about metformin, you were talking about an ACE inhibitor, you're talking about a statin, and you're talking about aspirin.
Yes.
And that's the type 2 tablet.
Right.
So you need a reason for someone with type 2 diabetes not to be on all four components.
Absolutely. Now, our next question from that previous person was about, would the effects of metformin in this patient be affected by alcohol? You know, he drinks the 8 beers on the weekend. What's the issue here? Or are we just going to say he's not going to drink that alcohol anymore?
I don't think the interaction is significant enough not to give it, if that's the question. I think cutting down on his alcohol intake would assist in a number of ways. It would cut down his caloric intake and he might lose some weight. He may spend some of that time perhaps walking rather than sitting and drinking on Saturdays. Or if he can't walk, maybe ride a bike. But no, I don't think I'd be worried about that.
The same person asks about, with a huge number of Australians being affected by diabetes and pre-diabetes, shouldn't education about this be implemented in high schools? Does anyone have a comment on that?
I think that's a good suggestion because it is really, and it isn't just in the high-risk population, such as Indigenous Australians. There are high-risk migrant groups as well. And so really there's a lot of diabetes now in young women, and it's either gestational diabetes that we'll be talking about in a moment, or pre-existing type 2 diabetes or undiagnosed type 2 diabetes. So it's very important, I think, to educate younger people in high school and to really convince them that they can do something and that they really need to do it at a young age rather than wait until they've got the disease, the condition. So there is a lot that they can do.
Now, Samaria, you're a big fan of education, aren't you? What's your comment to this question?
I think we should be out there educating everybody from high school onwards, primary school. Take the cool drinks out of the canteens, more healthier foods.
Yep.
Change the trend, because it's Karen reckon it's a silent disease and it just sneaks up.
And given that it has no symptoms whatsoever in the main, that it's often found by screening, we've got a captive audience with this gentleman's family. They're at risk already, his children and his grandchildren. So we could perhaps start with our education within those family groups. But I agree with Samaria that even primary school, and I think in remote Australia we actually do more of that perhaps than in other places.
Can I make a comment there that the International Diabetes Federation is actually running a campaign this year and next year, 2 years, And the campaign is focused around children get diabetes too.
Right.
And I'm wearing the logo for the International Diabetes Federation, so I'm giving them a plug. But it's a useful resource. They've got some good, interesting things that they've said about type 2 diabetes in children, and they've identified that it's going to be a major cause of future morbidity and mortality. The first time perhaps ever in history that our children will live for a shorter period than us.
Frightening, isn't it? But that's actually very relevant to another question we have from Marissa, who asks, with so many people being diagnosed with diabetes, should we be doing earlier screening and treating the pre-diabetic group with metformin? So are these children likely to be treated with metformin?
Well, Karen may have a comment too.
I will.
Well, I think that the short answer to that of treating pre-diabetes in children is that it hasn't been done. So there really isn't any evidence to say it's a good thing or a bad thing. There is some evidence that I'm sure Karen will outline about metformin in adults with pre-diabetes, and perhaps Karen.
Yeah, I think we should, before we go to metformin, we should be treating pre-diabetes with aggressive diet and exercise. And I think there's good international evidence that both metformin and diabetes and exercise and diet can prevent diabetes, but exercise and diet being more effective. And in older people with diabetes, if I recall, metformin is not effective, diet and exercise is more effective. In younger people, metformin is effective, but I would still argue first for diet and for a lifestyle approach,
right,
before going to a pharmaceutical approach.
Well, we have another question.
And the reason being that there'll be a whole lot of other benefits from that.
Right.
That it won't just affect your risk of diabetes. If you have regular exercise and a healthy diet, then your risk of a whole lot of chronic conditions will go down.
Yes.
That's the kind of thing we've got to think about. Holistic health, not just one condition.
Absolutely. Actually, speaking of that, we might go on to the next slide about this gentleman. We know he's obese because he weighs 109 kilos. And he has a blood pressure of 155 and 100. His BMI is 34. But the big thing I wanted to bring up here is he's got dental caries, indicative of periodontal disease. So, Pat, I wonder if you could just briefly talk about this association between diabetes and oral health, and how we can help our people out there in rural and remote communities be more aware of this link between diabetes and their teeth.
And it's a very strong link. It's a link two ways. One is through caries, and the second one is the one that's identified here, periodontal disease.
Right.
And periodontal disease is really quite a nasty condition. It can actually cause abscesses in your dental abscesses. It can cause problems in sinusitis. It can cause systemic infection. The inflammation itself may be deleterious, and then it makes you lose your teeth. And of course, if you lose your teeth and you've got diabetes, many of the healthy options become more difficult for you to manage. So I think the major thing is to remember that you need to check teeth. It's one of the routines that you should have in your diabetes monitoring. Teeth is one, eyes is one, teeth is one, feet is one, and so on. So you need those routines. And we were talking earlier about how you can actually identify. Well, one of the ways is a sniff test. And quite seriously, although it's said a little bit flippantly, it's quite true. People smell like they're rotting because they are actually rotting, and that's what's happening to their tissues.
Who's supposed to do the sniffing?
Well, if you're brave enough.
Not me.
No.
I think with what Pat has said, I'd say this is all part of a chronic disease management plan. And as part of that, as you've identified, regular dental reviews, and ophthalmological or optometry examinations, and when possible podiatry examinations. In rural Australia and certainly in remote Australia, these resources are not available, but many people in remote clinics have actually had training to identify some of these things, even some of the dental problems. And most practitioners can have a look at fundi and certainly feet. And as a chronic disease management plan, these should be timetabled along with everything else that's going to happen to this person. This gentleman probably needs addressing his immunisation status.
Yes.
Clearly his blood pressure needs addressing, as we talked about before. His lipid profile. So he's got a whole range of things. And I'm thinking that if we get him to self-monitor, review him fairly frequently, give him some support and the family support, because he's got to live in a remote location. He's got to have access to cheap foods that are healthy, and he's also he's living with a family of some 8 people, and that has to be factored in meal preparation. And I think that if over time we don't get some good response with the oral medication, then I think early introduction of insulin is, in addition to the metformin that is, should be considered.
Now, on that point, we have a question from one of our viewers about hypoglycemia. Now, I understand from some of our previous discussions that people fear going on insulin, particularly in a rural setting, because they think they're going to get hypoglycemia. And this person says, does it have too much of an emphasis? Can we have comments from the panel? So, you know, putting this guy on insulin is...
Yes, first is that type 2 diabetes does not produce the hypoglycemic episodes that you see with type 1. There are people who have been used to blood sugar levels of 15 or 20 or 25 who will feel a fall in their blood sugar. But in fact, blood sugars of the order where you'd need to be really concerned about loss of consciousness and intervention by another person, they're going to be down around 2.5 or thereabouts. So no, I don't think it actually is a great issue. And the control of the complications of diabetes is glycemic control. And insulin will do that, perhaps in combination with metformin. And it should be considered early, and with the newer insulins particularly, and a long-acting insulin again, hypoglycemic episodes are indeed rare. So a basal long-acting insulin, and Samaria has some experience in managing people like that, that will prevent that from happening.
So on that point, Samaria, how do people out in the remote communities access all the equipment that they need for going on insulin? Needles, syringes, disposal kits?
All right. Firstly, they're flown in to Darwin, to the hospital. We do all the screenings, we stabilise them, see what's happening within their system, and then recognise if they need what their fasting is in the mornings. Normally, we try and get with the gestationals 5.5, and that's pretty tight. And with their elder type 2s, and we try and get the fasting around 7 to 8.
Right.
So it's pretty tight.
And so they can access their equipment through the diabetes scheme?
They do. They sign up with the NDSS, and that's with Diabetes Australia. They get their strips at $1 for 100. And if they can't afford that, we'll set them up with a monitor and monitor them through phone or fax.
Oh, that's terrific. Now, just we also had a question about whether HbA1c is always accurate. So, Pat, I'll put this to you. Are there times when the HbA1c is inaccurate for people? And if so, when do you use that other test called fructosamine?
Right. Good questions. And I guess sometimes you do see a blood glucose profile that suggests that the A1C should be higher or lower than it is. And just as a rough rule for people, the average blood glucose is roughly twice the A1C minus 6.
Oh.
So twice the A1C minus 6 is the average blood glucose. So if you're looking at a profile and you're seeing a lower blood glucose than the A1C would suggest, there's a couple of things you ask. Is it the blood glucose that's wrong, or is it the A1C? Usually is the blood glucose. For example, people will measure in the morning because it's often the lowest value, and so they like to get good numbers. They may not wish to include the bad numbers. Their meter may be wrong. So occasionally there is the discrepancy and it's the blood glucose. Sometimes it is the A1C. And remember that hemoglobin lasts in your blood for some time, and all that time is getting glycosylated.
3 months, isn't it?
Well, 3 months, yeah. Certainly a fair period of time. And under those circumstances, if you shorten the lifespan of the red cell, the A1C, of course, will be lower, and spuriously lower.
Yes.
And that does happen sometimes. Usually it's pretty rare. There are some funny hemoglobins that cause problems, but the laboratory should be able to tell you about that. So you've got so far we've got the blood glucose, the A1C, and then if you're still not sure, the fructosamine gives you another check.
Well, so what is fructosamine?
Fructose, just as hemoglobin A1C is hemoglobin glycosylated, fructosamine is albumin glycosylated.
Right.
And albumin has a shorter half-life than hemoglobin and therefore turns over more quickly.
About how long?
Well, it's got a half-life of something like 10 days, so you're looking at, you can see a change in glycemic control in weeks.
And is that easy to order, that test? Could Hugh order a fructosamine up there?
You could, but
I'm sure it is possible for us to order it. Actually, given the 350 kilometres and the wet season, the issue would be getting the specimen out of the community. There are now a number of sites that actually have point-of-care testing. We're a small unit that has cartridges, can do ACRs and HbA1cs, so we can do those tests on site, and they're even covered by Medicare rebates.
Oh, terrific. And I noticed that our patient here has an ACR of 4.6, that's an albumin-creatinine ratio. Is this a standard test that you do in diabetes patients?
Well, in the Northern Territory, an ACR in remote Australia is logistically a lot more easy to do on a early morning specimen.
Can you just briefly tell us what it's about in case anyone doesn't know what an ACR is?
It's actually the urine specimen where the albumin content and the creatinine content, it's the ratio between the two. And it's a measure really of microalbuminuria. And it will tell you if you've got microalbuminuria or even indeed macroalbuminuria. So it's suggesting that this person, for whatever reason, it may be diabetes or it could be hypertension or other issues, previous renal disease, that they have got a potentially reversible renal damage. And that would be addressed with the addition of good blood pressure control, good glycemic control, and also an ACE inhibitor.
So this guy, getting back to our patient, our 43-year-old grandfather, he's potentially going to be on, 4 or 5 medicines. We're telling him he's got some serious health issues. How do we motivate him to think that there is some hope?
Well, I suppose one of the issues is for him to see good need, and I can see this gentleman. He's probably passionate about his children and his family. I'd probably encourage him to work hard to be there for them and fit enough to enjoy activities with them, such as his fishing and hunting. Also, I might even suggest that there's some calculations that we could do for cardiovascular risk, and I believe that there's a slide that will show how we can calculate it.
The New Zealand risk calculator.
And this is just one tool. This is a calculator for cardiovascular risk, and indeed this gentleman has got certainly cardiovascular risk as well as risk associated with his diabetes. And
so he's up in the red section already, isn't he?
He's up in the red section because of his cholesterol ratio, his blood pressure, his weight. Other factors are included, whether he's a smoker, and gender and age. So he's getting into that red section already. And that may be enough for him to have a visual idea of where he's headed. And in this case, he would have more than probably 20% chance of having a cardiovascular event, a significant cardiovascular event in the next 5 years.
That's a very handy tool, isn't it, that risk calculator? That's just available on the internet, isn't it?
It is, yeah.
So, just in summary, is there any time that at this point where we'd need to refer him to a specialist in the big smoke? Do you think, or can you manage him in your clinic?
Many rural practitioners and remote practitioners and their team, the team of people they work with support from people like Samaria, could manage this person. And occasionally you have the opportunity for visiting physicians that may come. I guess it's when they start to get complications like foot issues and so forth that they need to go to a major centre. But now with increasing supports like telephone support that the Diabetic Service in Darwin provides, I think that's possible in a lot of mainstream, other places, and Pat's been involved in some of that in South Australia.
Yes. So we can quickly just cover some of the resources that are out there available for practitioners out there. For example, the CARPA manual that we have a slide of. And Samaria, do you use this manual in your practice?
Yes, we do. And it's a guideline. And a lot of the health workers, a lot of the GPs and a lot of the nurses use it as a guideline in remote areas.
Right. And we also have the RACGP new guidelines on managing, is it just type 2 diabetes or is it all?
Type 2 diabetes, yes.
Right. Now, let's go to our second case study. And this woman is a case of pre-existing diabetes in the gestational setting. So, this is Blanche. She's 32 years of age. She's married. She has 3 children who are 6, 7 and 10. They live in a remote community and she works at the local school. She has a history of type 2 diabetes for the last 2 years. She has hyperlipidemia. Her HbA1c at the moment is 9.7%, but it was previously 11.9% 2 years ago. Her ACR is 1.5. She's got a creatinine of 54. Her lipids are controlled, except she's got a triglyceride level of 2.1 and an LDL of 1.3. She doesn't smoke and she doesn't drink, but she has a BMI of 28. Her blood pressure is 100/60. And she's on metformin 1 gram BD, glycoside MR 30 milligrams a day, and atorvastatin 20 milligrams. So, Hugh, I'd like to put it to you that this woman was present to you. She's 14 weeks pregnant. She's got this history of pre-existing diabetes. And what would be the sorts of things that you would be first looking at in your assessment of her?
I think probably as with other diabetic patients, the first thing is going to be to support her and motivate her, and being pregnant is a very good motivator because perfect glycemic control in this woman is going to produce the best outcomes. And this is a case not of gestational diabetes but of pre-existing diabetes. That may have consequences for the baby already in terms of any congenital abnormalities, and hopefully she will not go on to have a miscarriage. It also will have consequences in her later pregnancy. So she's going to need excellent glycemic control. Hopefully also continue those other things with diabetics, such as regular exercise, and she's a little bit overweight, so perhaps some weight control as well. The process for doing this, I think, would be to have, again, a robust plan for her. She's going to need regular reviews, and we would actually, the health workers and remote area nurses and midwives will monitor her every 2 weeks until she's 28 weeks, and then after 28 weeks weekly. And she's going to have baseline bloods done that are important. She's already had some of them, HbA1c, but she may also need things like a thyroid function because that has effects on your metabolism. I think you could consider some of the issues that will arise according to some of the issues regarding the baby. And I'd be interested to know what her previous obstetric history was, what size the babies were, whether there was any dystocia, and whether or not she also had any complications such as toxemia at the time. And to plan to the outcome, which would be the timeliness of her delivery and the mode of delivery. But one essential ingredient is going to be early in this stage she needs to stop certain medications such as the statin and the sulfonylurea, and also to perhaps, it's a little bit late, but perhaps consider adding folic acid as part of a normal pregnancy.
Even though she's going into her second trimester?
Well, again, it's probably not going to have the same benefit if you had started it pre-pregnancy.
Yes.
And
why would you bother then?
Well, I speak because they nearly always get iron and folic acid combined anyway, because of anemia in our population. She needs an early scan for morphology, and she also needs a later scan for sizing of the baby.
Can you do those scans in your surgery?
We have visiting ultrasounds, and I can do my own ultrasounds. Again, it's resources if you've got the equipment to do it. And she also, later in her pregnancy, is going to need scans to look at both macrosomia but also IUGR, because they're potentially both complications of
IUGR?
Intrauterine growth retardation.
Thank you.
So indeed she may need either a big baby monitored, or in fact indeed a small baby, which may involve Doppler monitoring of the umbilical blood flow.
Looks like you're going to have her in your surgery for about 2 weeks.
She's going to be coming very frequently, but along the pathway, part of her management plan is going to be an early referral, ideally to a specialist centre, such as the case that the clinic that Samaria works with, for early insulin use.
I guess one of the, not complications, but the difficulties in a remote setting is that people present later in their pregnancy. We've got this lady at 14 weeks, but what is common for you to see? I understand it's more like 37 weeks.
Well, indeed, I think it depends on the community education, and I think health workers are integral to that. The relationship and education that you have. If you've been doing a program in schools, talking to girls pre-pregnancy counselling, then they come to understand the benefit of that early presentation. But you're also right that many times it's when somebody is in labour that you have to deal with the problem.
Goodness. So Samaria, could you give us a bit of insight into how you help pregnant ladies like this from your clinic or your service?
I work within a team, and what we do, we get them brought into the hospital. We monitor their BGLs, look at their fasting sugars, do their HB1AC, and we work from there. And with this lady, we'd continue the metformin and put her on a basal bolus of insulin. And normally that's Protophane and Novorapid.
Right.
And then we'll educate her, and within our team we're consistent with the messages that we deliver, and we do the educating on injecting insulin safely, and we go through hypos and hypers. We cover a lot of things with them.
And you communicate with these people by phone on a regular basis?
Phone and faxes.
And when is it you say they have to be, you ask them to come to the hospital close to delivery?
Yes, because they're at risk of complications.
Right.
So they come in at 38, depends on what their risk factors are.
And this
if
is
their risk
Indigenous
factors are
and
higher,
non-Indigenous pregnant women?
Yep, it doesn't matter.
Just if you've got the diabetes?
Yes,
Right.
yes. And like non-Indigenous ladies get it too.
Right.
So it's not an Indigenous thing.
And this woman, be she Indigenous or not, needs a lot of support. Also, her family needs a lot of support, because when you start talking about insulin therapy, you're talking about regular monitoring every day. She's working, that's going to impact on her capacity to work. It's also, she's got a number of children to care for as well. So I think it's again another example of where you get the, as Samaria does, gets the whole family involved in the support.
Now we have a, oh sorry, yes.
I was just going to say, she also illustrates a very important point in women of childbearing age in general, and that is diabetes is associated with a lot of nasty drugs for pregnant women. And if there's a young woman who is not on reliable contraception, then maybe you shouldn't be using an ACE inhibitor, maybe you shouldn't be using a statin, maybe you shouldn't be using a sulfonylurea.
That is exactly right, because that's what the question was I was going to read.
Okay.
Incredible timing, that
Sorry.
shouldn't this lady be off the atorvastatin?
Yes.
So what's your advice
Well,
there?
I think I was going to actually ask you, but I mean, many people have found that using a contraceptive such as Depo-Provera is actually not a bad way to go, in the sense that you don't have any periods and you lose and you become, it works very effectively as a contraception. And then you feel much more comfortable in prescribing potentially teratogenic drugs, like the statins, like
ACE inhibitors.
Sulfonylureas. So, and I was going to, I don't know, Hugh, if that is something which is practiced in...
In fact, it is indeed the main way. In fact, I'd say that there are very, very few people in remote communities that actually take the oral contraceptive pill. It has been the Depo form that's been available in the past, and more recently it's been implants that last for 3 years, and that way that you can actually give a lot more confidence in giving these medications to potentially pregnant women.
We had another faxed question that was asking about which is the most appropriate contraceptive method for pre-diabetic, diabetic women, given the propensity for some of them to cause weight gain and metabolic consequences. So is this again when we might go to a IUD?
I think that is a case, but I think that they actually have. I think that some of those are perhaps overrated, the metabolic effects, versus the possibility of actually being pregnant and being diabetic.
I think the advantage of the depot or the implant is that they're there and they don't require anyone to take any pills, and so they're reliable. Now, you may say that the depot progesterone, for example, does have some metabolic side effects of its own. That's true, and maybe the vaginally uterine implant is a good way to go in terms of contraception. But I think the issue of contraception in women of childbearing age and diabetes is a really important one, because you get nasty things happen to the babies.
Are these covered in the Australasian guidelines for diabetes and pregnancy? Thank you. Is that the sort of thing it covers?
They do talk about the medications, as most of the viewers will know. In the pink book, you've got all the medications which are not supposed to be used in pregnancy.
Yeah, the drugs, ADEC, drugs in pregnancy, yes. But management of contraception?
It's not as thoroughly covered either in the RACGP guidelines or in the ADIPS. But I don't think it's rocket science in the sense of you want something, if possible, which is given as infrequently as possible and as effective as possible.
And Samaria, I mean, in your clinic, because this is an issue at the end of this woman's pregnancy, that she actually needs reliable contraception because she has got diabetes, and so she actually needs some advice about that. We're not talking about gestational diabetes that's going to need retesting over time. And in your clinic, do they discuss the contraception when they go back home?
No, we let the community base doctors talk to them about that, but we make sure they have their follow-up OGT test. But this lady's already pre-diabetes anyhow, but with the gestationals we make sure they have the 6 weeks check-up afterwards.
I have a doozy of a question. If you're interested to know who wants to answer it. From Marissa again, I have read on PubMed that having a teaspoon of apple cider vinegar at night before bed helps to stabilise blood sugar levels. Anyone?
Well, every year, every week almost, there's another cure for diabetes, and I suspect that might be another one of them.
But if it's on PubMed, it's likely to be an abstract of a paper.
Yeah, well, there's lots of papers which are published in abstract, and they never get into a full reputable journal. So I take most of these things with a big grain of salt, because the trials which have been done are frequently small, and they may have a positive result, but they're small trials which are not the sort of reliable trials on which you would base recommendations. I think one of the things that comes out of that sort of issue is I'll take the apple cider and I won't need to take my diabetes tablets.
Yes.
So if people are going to try these things, they should. I think it should be strongly recommended that they check that they're not going to interact with their prescribed medication, and don't stop their prescribed medication without talking to their doctor.
Yes,
and
that's
indeed
right.
there are a number of medications that actually do produce hyperglycemia, and there's we're talking about natural products, and there are some that interact with other drugs as well.
Yes, they certainly
so
are.
people need to get good advice. I mean, glucosamine in our first case scenario may indeed contribute to a small extent to glycemic control.
Yes, there's been studies to support that, haven't there? Karen, I was wondering if you'd like to comment. We'll get back to our case just briefly before we try and wind up. What your advice would be to this woman at 14 weeks in her pregnancy, pre-existing diabetes, to help motivate her along to keeping healthy?
Well, I think she'd be motivated with wanting to ensure the health of her baby, and so I think she'd be highly, I mean, I'd be surprised actually that she hadn't been to the clinic before 14 weeks, so that's probably not a good sign. because if she really didn't know she was pregnant. But I think she'd probably be highly motivated for a good outcome, and I think just compliance with the instructions that she's been given, and regular monitoring is very important.
And Samaria, you also said you'd be making sure she goes for a walk every day or something like that, is that right?
Yes, encourage exercise and eating healthy, yes.
Yeah.
Yes. And even if it's around the house, you know. Some communities have got dogs and other problems in the community, so yeah, it's 30 minutes, that's nothing really.
Well, I think we might try to summarise now and ask each one of you for your take-home message to our viewers. So Hugh, could we ask you to start, please?
Yes, I'd promote the concept of having systems in place, and systems can be your register of your diabetic patients and recalls and reviews, and a robust chronic disease management plan for diabetes that has timetabled events. I'd keep it simple and achievable though, given rural Australia doesn't have all of the resources that other places do, and I'd encourage also considering the early use of insulin. Keep it simple but very effective.
Samaria?
Just setting realistic goals for your patients. Everyone's human, and small changes are better than no changes. And eat what you normally eat, traditional food, and slow down on your introduced foods.
Wise advice. Karen?
Well, I'd like to add to that. I'd like to encourage people to think about prevention. So in young people, to try and prevent excessive weight gain through a healthy diet and active lifestyle, not through diet alone. And in older people, and perhaps people who've already gained some weight, to actually recognise that even if you don't lose weight, a healthy diet, a Mediterranean-style diet, rich in plant foods if you can, so lots of fruit and vegetables, olive oil as your major fat, and regular exercise will be very beneficial for you. I have two concepts that we're interested in. Try and change yourself from being metabolically unhealthy to metabolically healthy, obese, and there is evidence that you can do that through diet and exercise. And then alternatively, you can think of yourself as being fat and fit. So those are two positive messages for people who are already overweight.
And Pat?
I suggest that people always think about the presence of diabetes and think of the F words, fat 40, family and fat, 40 family and fat. Then think about the risk of complications, which is the ABCs, the A1C, blood pressure, cholesterol, smoking, salicylates. Then think about treating them, which is the type 2 tablet, which is metformin, ACE inhibitor, statin and aspirin. And finally, the importance of cardiovascular disease in type 2 diabetes.
So much to remember, but wise advice. Well, I hope you've enjoyed this program on sugar in the bush, rural and remote diabetes. The case studies in this program were developed by the Menzies School of Health Research. If you're interested in obtaining more information about the issues raised in the program, there are a number of resources available on the Rural Health Education Foundation website at rhef.com.au. Don't forget to complete and send in your evaluation forms, and please register for CPD points by completing the attendance sheet. Finally, our thanks to the Australian Government Department of Health and Ageing for making this program possible, and thanks also to you for taking the time to attend and contribute, and thank you to our panellists. I'm Geraldine Moses. Good night.